So on to chapter 5 in Essential Science for Therapeutic Massage. And the study process, the study pattern should be becoming familiar to you now. And so what I want to do is highlight the more important areas related to the exam, as well, the MBLEX exam, as well as what is relevant for you to become your own best teacher, and information that you will want to continue to explore as you move into and through your massage career. So here we go. There's the beautiful cover of the textbook. And I got to get my glasses on so I can see, make sure no hair is sticking out and distracting there. And then down we go to our table of contents. And here is our chapter 5, peripheral nervous system. So last time, the last video, we talked about the nervous system overall, and then more specifically on the central nervous system. So the peripheral nervous system is all of the stuff outside of the central nervous system. And there is language here to learn. And so a lot of this chapter is going to be related to developing an understanding of the vocabulary. So here's all the nerve stuff. What is it in general? And then the reflex mechanism, which is part of the stimulus response feedback loop idea. And then the autonomic nervous system, where massage therapy really interfaces. And then a short version on the other 5 senses. And then in addition to that, we've got the 5 basic senses here, but there are other ways of thinking about these senses, and proprioceptive and vestibular mechanisms sometimes can be categorized here. And our pathology section. All right, chapter objectives: be able to know your key terms, pay attention to learning how to learn. Here's your overview, and then here are the basics for the peripheral nervous system. In this section, we are going to cover the pieces of the peripheral nervous system, take a look at the cranial nerves and the function of each one. You're going to want a working knowledge of that, but not necessarily a memorization related to the MBLEX exam. One of the ones that massage interfaces with most specifically with is the vagus nerve. And the vagus nerve is functions with breathing as well as the intestinal tract. So we also want to have a really good understanding of the major nerve plexuses that come from the spinal cord, and then they form little pathways for going down into the limbs or up into the head. So the nerves themselves are like a wire, but they're actually more like a worm, and they have the shape is determined by these coverings. And this is also where the healing mechanisms occur, is in these connective tissue coverings of these nerves. And you probably are going to want to have a definition recall on these. Sometimes these words specifically will show up on the licensing exam. Always stop and kind of pay attention to the pictures here, kind of get a sense of the organization of how the nerve itself is together. You can, these types of schematics sometimes make it a little easier to understand that. So the terms here are something, again, that you're going to want to have a working knowledge of, be able to recognize them if you read them, um, have enough familiarity with them so that if it shows up in a report or something, that you can more quickly cover and come up with a question so that you can learn further about it. So here are these cranial nerves, and there are a bunch of mnemonics on how to remember all of these. It might be a fun research, YouTube research, to come up with mnemonics on the nerves. Like I had said, they're all important, but the one we interact with a lot is the vagus nerve and also the facial nerve. The trigeminal nerve also comes in and covers areas that we can come into indirect contact through the skin. So here they all are and what they do. And then more on the vagus nerve. So slow down, pay attention here. And then recently there has been more focus on this polyvagal theory, that the vagus nerve and its function and how it relates to the nervous system is part of a survival mechanism. So do stop, pay attention to this a little bit. You might even want to look at some of these individual studies. Always pay attention to your little practical applications. And then now we get into the spinal nerves. These are the ones that exit through the vertebrae. The vertebrae stack one on top of each other. Then that protects the spinal cord proper, which is part of the central nervous system. And then the spinal nerves track out through the little holes. So here's the distribution. And chances are you will encounter a question related to this, how many thoracic nerves are there and how many lumbar nerves in the plexus. So kind of review that more frequently. So here is the table. So the cervical neck area has 8 pairs. So this and the abbreviations are something that you're going to want to know. And then the plexuses are important. So here's the cervical plexus. And if that is, nerves are like worms. So if you press on them too hard, they're not going to like it. And so if the way in this area, if the way the head is located, or if there's tight muscles or connective tissue in the area, or there might be a change in a bone here that makes the hole that the little spinal nerve would go through too small, or whatever these causes are that presses on these nerves, then you're going to start to get a particular radicular or radiating pain. So the cervical plexus is going to kind of go up into the head and the base of the skull. What's nice when you learn the names of these nerves is they kind of can give you some clues. So you'll see when you're looking at this picture here, you'll see like lesser occipital nerve, that if when we get into the bones and joints and muscles, when you connect that location, your occiput, that will give you a cue to where these nerves are at. And then we have the brachial plexus. So this one can be an issue with headaches, cervical-based headaches. Also, it can kind of go into the jaw a little bit, so think from the neck up. With the brachial plexus, this is the one that goes down into the arm and behind the shoulder blade. So that's that when this one is crowded, where the nerves are being pinched in an impingement situation, they will usually call this thoracic outlet syndrome, sometimes thoracic inlet syndrome. And then the lumbar plexus, this is the area where you would feel it around your sacroiliac joint. That's there where your hip bones join onto the coccyx and the torso. And you can feel it into the gluteal area or down the leg. And this is a very common area for the structure to change and for nerves to become crowded. And then the sacral plexus is more located into just the tissues right around the sacrum. And that sacroiliac joint pain is common, and the nerves are usually active in that discomfort. So nerve injury or nerve sensation itself is difficult. It tends to run on a line, it throbs, sometimes it's positional, you just move a certain way and it's hot. So these sensations, excessive sensation, decreased sensation, numbing and tingling, loss of sensation, this is part of what would happen if there was a nerve injury. Also, you can have impaired movement, different aspects of paralysis where the motor function is interfered with, a weakening and an atrophy. So when upper motor neurons are damaged, then you're going to have some spasticity and some stiffness. And then if you've got a lower neuron area, lower motor neurons, you're going to have weakness, loss of muscle tone, flaccicity, diminished reflexes, and progressive muscle atrophy. The upper motor neuron injuries that have some spasticity and stiffness, as disconcerting as that is, at least that intermittent contraction on the fluid, the blood vessels and the fluid lymphatic can sometimes be pushed through, or the movement of the fluid is a little bit better and a little less so without the muscle tone and the flaccid paralysis. So this is asking you to do some critical thinking. What would happen if the phrenic nerve was disturbed? So you're going to have to go up and look and see what the phrenic nerve does. And then you're going to go, well, what would happen if there was a problem there? Okay. Myotones and dermatones are nervous system organization. They develop in fetal development, and the dermatome talks about how a skin and reflex mechanism is supplied by a particular nerve root or series of nerve roots. So a way of diagnostic nerve injury is to locate where the symptoms are, and then you can sort of determine if that is um, coming from, so down the side of the leg here, starting laterally and going medial, that would be a nerve root L4. So just gives you a little bit of an idea of how you might determine where the actual impingement or the actual dysfunction is coming from. Myotomes are organizations of functional motor units, functional muscle connection. And so if there has been a nerve damage at C2, then the movement of neck flexion, for example, is going to be disturbed. So it gives you the myotomes related to the movement here. These are helpful. Probably won't show up the MBLEX exam, but really helpful. If there is just shortening in the area around L2, lumbar 2, for example, and aggravated, or there's a symptom increase with hip flexion, then you've got a location to go look close to the spinal column. You can look there and start there to work your way out to see where the compression on the nerve might be. Same with all of these. So here's your review, what you have learned. This is going to take you back to some tables. Remember, figures and tables and boxes tend to concentrate information. And then the body doesn't necessarily operate with one nerve stimulated and one muscle acting. It's a communication, and it's efficient. So a reflex is a predetermined response. And a lot of general postural information, breathing, most organ interaction, these are all coordinated by reflexes that are like pre-programmed. They're used, a reflex is often used, for diagnostic purposes, to stimulate a reflex and see what happens. So when they're doing a new birth, they're looking at the new baby, the pediatrician will often go through and check for certain kinds of reflexes so that they know that the nervous system is responding appropriately. Most are complex. Some are simple, and you've kind of seen examples where somebody will take a little hammer and hit just below the patella at the knee, and the leg will pop out. These types of reflexes are what you're pre-programmed with when you're born. You already have all these. As you start to learn to walk, or you practice a particular activity over and over, the nervous system starts to learn how those dermatomes and myotomes and all that kind of stuff need to coordinate together. And over time and with practice, it becomes a unit. And those are your complex or conditioned reflexes. An example of this that we often hear about is the Pavlov's dog, that you ring a bell, and then you put food down, and then pretty soon all you have to do is put the food down and you get the reflex response of the digestive system, or you just ring the bell without the food and you get the pre-programmed response of digestive system turning on. So we have a series of reflexes here. Somatosomatic. This is a coordination between muscle, bone, joint, and another muscle, bone, joint function. Then we have somatovisceral, and that's an interface between the cutaneous, subcutaneous muscle sites and something going on with an organ. So when somebody has an inflamed appendix, for example, the area over top of that in the abdomen will get rigid. The visceral somatic reflexes, actually what I just gave you was a visceral somatic reflex where you get a change in the soma in response to a problem with the viscera. And then visceral reflexes is the crosstalk, the reflex interface between two internal type responses. We do interface with sensory receptors. We do interact. The process of massage does stimulate these reflex responses. So this picture here gives you the main listening stations in the skin, and you're going to want to have a working knowledge of these. Free nerve endings often are what they will call nociceptors that detect tissue damage. The root hair plexus is interesting. It responds to the movement of the hair, and sometimes you're aware of a breeze that is moving the hair, and then that will stimulate that receptor and cause you to pay more attention to something. Certainly, all of these are involved in the recognition and sending signals about touch. And then deeper into the structure, the positional receptors and the stretch receptors, and we also have joint receptors around joints that talk about how strong is the contraction, is the tissue getting longer, is it shortening, and what we are trying to do with massage is modify our methods so that we're speaking a language that would be more likely understood by a Golgi tendon organ, for example, or a Meissner's corpuscle, a tactile corpuscle. So receptor function adapts over time. And some of this habit of stiffness, the somatic habit of stiffness, or a sensation of pain can happen because these receptors have adapted, and then they start to respond to a different pattern of signaling. Additionally, receptors will adapt either slowly or quickly, so that you don't necessarily have to constantly pay attention to something. So clothing, when you put your clothing on in the beginning, you'll feel it, and then you sort of can ignore it. Not everybody gets to do that. Some people have somatic hypersensitivity, and then they can't stand the tag in the back, or it itches or picks or whatever. So we also have these sensory structures, these receptors, these listening stations are stimulated by mechanical pressure, mechanical force, mechanical receptors. So, which is what massage does. Creates a push or a pull, which is a mechanical force. Now, these C-tactile fibers right here, there's been quite a lot of current research on these in relationship to effective touch and how touch creates a sense of safety. And so you might see some research about these C-tactile fibers. So with massage, what we're trying to do is learn to speak these receptor mechanisms language. Now, kinesthesia, this is the body sense. I mentioned this earlier in a previous chapter about how we orient ourselves in space, how we know if we're standing up, laying down, what happens if that becomes distorted. So proprioception is our body sense that enables us to monitor our position of our body. And here are the receptors that do that. And we can pretty directly interface with these receptor mechanisms. When we do an inhibitory pressure in the belly or the bigger part of a muscle, for example, we're talking to muscle spindles and we're making them think that they're doing something that they're not. And so then they have to, that goes up into the central nervous system, processed, and then comes down through the motor response. And hopefully that muscle will relax a little bit for us. That's kind of an example of how this works. When we do active and passive joint movement, as well as when we have the muscles respond to all of that, like is commonly found in an approach called muscle energy technique, where we move the joint into a certain position, and then we have the person push or pull against that, and that stimulates both these kinesthetic receptors up here, proprioceptors, as well as these joint kinesthetic receptors. So that's one of the reasons why incorporating active and passive joint movement routinely in the massage is that you're generally stimulating these responses, and then it kind of signals the body to take a look, and then we get a homeostatic reset. So this talks about how massage introduces a stimulus, just what I've been talking about, and then how that stimulus eventually gets to a response that should hopefully help us achieve the outcome from massage. This is another activity that is going to help you take the new information, this language, and manipulate it, help it go into long-term memory, and then help you retrieve it in a novel way. So make sure that you do these. So a reflex arc is a shortcut to these reflexes, and there are some, particularly those connected with survival mechanisms, have got an actual shortcut embedded in them. So here are some deep tendon reflexes that often are checked to see if the nervous system is responding. The stretch reflex and its response with reciprocal innervation, where if in a motor unit, in a functional muscle unit, when one muscle shortens, the muscle that is its direct opposite would have to lengthen to allow that joint to move. And that lengthening signal is the inhibition. So muscle functions are always communicating back and forth, so that when one shortens to create a movement, now the opposite group has got to then eventually contract it to bring it back into anatomical position. The cross extensor reflex is fun. If I think I'm going to fall, and then my whole body is going to signal that. So I've got kind of a funky knee. And if that knee starts to signal, that'll be more local. I'll do stuff right around that knee reflexively, but I'll also have stuff that happens on the other side of the body to help me maintain balance so that I don't fall. So that's why sometimes you can uh, massage the opposite limb and get a result, even though you're not targeting the area that is short or painful. And that's kind of a fun way to do massage. And this reflex interaction is tied right into our gait. So we'll tell you, you'll learn the right arm it is through reflex patterns connected to the left leg. And that has to do with this innate patterning for us to stand up and to walk. Tone is the density and the stiffness and the shortening of the muscle structure. And typically, what massage does is works to restore a more normal tone. And we do our best job with that by working with tissues that are stiff and short and helping them be more pliable and longer. If this, however, has to do these tone changes have to do with damage in the nervous system, then the massage is probably not going to be as helpful there. It might help temporarily. So, but it does help us understand why certain structures would become shorter and stiffer. And the fascia becomes a big important part of that because it connects these individual structural units, the right arm to the left leg. That's all kind of connected with a interlacing fascial movement, and there's nerves embedded in there, and there's certain reflex structures that are common in the area. And the fascia actually wraps and protects nerves. And the receptors that we stimulate, they're embedded in this tissue. So it's kind of important for us to have an understanding of how these integrated somatic and autonomic patterns of detecting information, interpreting it, and then responding, the relationship to the fascia. So there's your review, what you've learned. And then we get into the autonomic nervous system. And this will be third time we have kind of looked at this. We looked at this actually the fourth time. We looked at this a little bit in chapter 1, and then mechanisms of health and disease in chapter 2. And then it was covered a little bit in chapter 3 and chapter 4. So this will be actually the fifth time that this content has come up. Each time you encounter it, it should become more and more familiar. So this is an example of how the textbook is scaffolded, and it takes information and spirals it forward for you. Each time it's going to be a little bit more complex. So here we're discussing the difference between these two branches of the peripheral nervous system, the actual structure of it. Here, this box is going to give you more information about the neurotransmitters that we talked about in the previous chapter. The idea of a freeze response and what that is. And this is sometimes talked about in when somebody is going through a traumatic type of event. They can't run, they can't fight, and so they'll freeze up. And it is a part of the sympathetic arousal, and it is a survival response. Here's our parasympathetic rest and restore, but again, it's going to take you into more depth with it. These activities here are going to ask you to compare and contrast. Sympathetic here, brisk walk for 30 minutes in the morning. Fast-paced, activate sympathetic functions help me wake up. Parasympathetic, eating a bowl of oatmeal before bed, signals digestion and helps make me sleepy. So you're going to be asked here to look at some autonomic nervous system activities and see if you can come up with some examples. Again, this is a learning, repetition, recall activity. This table is going to give you a consolidated content on what happens if it's a parasympathetic response or a sympathetic response. This is going to feel a lot like way back when we talked about the balance of opposites, yin yang. So, for example, if we get down here, find one on the heart rate and contraction force is decreased, but under sympathetic response, it is increased. You're going to want to know this. And then here's that Eastern-Western connection I mentioned. This is the section on the 5 basic senses. You won't get a lot of MBLEX-related questions here, but a general knowledge, a general awareness is important for you to understand in overall how our body obtains information, processes it, and then responds. So here we've got our balance or vestibular sense. We've got a thermal or a temperature sense. And there's actually a whole therapeutic thermal therapy aspect that we usually shows up as part of the scope of practice for massage. The kinesthetic sense gives us an idea of our positioning and movement. It's part of interoception too, on how we, it is what's going on the inside of us a little bit, and how I discern, oh, that's just my stomach movement. It's not, some odd thing going on. But somebody who doesn't have this visceral part of this, that might feel very distressing to them. People can't screen out their normal heartbeat. And so we all have little irregular heart rhythms once in a while. But for somebody that is hypersensitive to that, it's in their consciousness all the time and they become hyper aware. Our pain sense, pain is very important. It is protective. It lets us anticipate the potential for damage or actual damage. And these pain is a distinct phenomenon and it intertwines with all the other senses, including touch. And that's why we spend so much time trying to sort that out. People also kind of sort of can orient to north, south, east, and west. And then here's our actual interoception, the appreciation and understanding of what's going on inside us. So we know we have to urinate if we have a full bladder, for example. So tissue damage, temperature, chemical stimuli, touch, these are all ways in our special senses that we process our world. So touch in particular is talked about here. it goes back. It's going to talk about some of the receptors we already mentioned. Then we've got hearing and the structures of the ear. Generally, you'll want to have an idea of this. Don't memorize, except you want to pay attention to the vestibular aspect. Vision, we do a lot of our positional, we combine a lot of our understanding of our world as well as ourselves in our environment is processed vision through the visual sense, and taste. And interestingly, in some of the Eastern ancient cultural systems like traditional Chinese medicine, um, they will check to see how the body is functioning by paying more attention to some of these special senses and their functioning. The sense of taste, have you all of a sudden everything tastes bitter or whatever. So even though we don't necessarily massage the tongue, if somebody might mention to us, my sense of taste has changed, that would be a cue for us to ask another question about what else might be going on with them, and then a potential referral. We can absolutely use the eyes for a writing reflex and its connection in with the inner ear during massage. So if I want a particular movement to occur, but I don't want to actually have the person move it, I can have them look in the direction they're going to move. So that presets the somatic part of the peripheral nervous system to move that direction. So if I've got a short tissues here in my shoulder, and I want those tissues to contract a little bit, so then they might relax, instead of bringing the muscles into actual activity. What I might do instead is just have the person look at the area and back, and look at the area and back, look at the area and back, and see if that will help reduce the tone. So slow down and read this particular practical application. Smell is a primitive sense. It is processed into our limbic system. Deja vu, I've been here, done that, often is triggered by a smell. We actually can smell emotion, and if somebody is stressed, they have a particular smell signature. So we, in the massage room, sometimes we'll use scents as part of the overarching experience, like a pleasant essential oil. So here we go with your review. And then here's this practical application on smell therapies. Our focus on professionalism. How do these special senses fit in with how we are going to set up our massage experience for our clients? So what kind of music are we going to play? How are we going to diminish the stimulation from the visual sense so that people can relax? And so read through this and it'll give you a little bit of some ideas around all of that. And then here are our pathologies. These pathologies are common, and so you're going to want to have a working knowledge of these. So here are the medications that affect the autonomic nervous system. And these are used a lot, these various blockers. and they tend to bring down a sympathetic response. So they're going to slow the heart rate. And but you also have some parasympathetic blockers that particularly are used for breathing issues like asthma or emphysema. And they do help dilate these vessels, but they also are going to rev up the sympathetic autonomic nervous system. So compression syndromes have to do with nerves being pressed on. And this is going to give you some guidance on what happens if it's the cervical plexus or brachial plexus, and what carpal tunnel is, which is a pressure and impingement type syndrome. And then your indications and your contraindications. Nerve root compression is going to have a broader distribution. We talked about the dermatomes a little earlier. Disc herniation, there's questions around whether or not it actually herniates or breaks down or squeezes out or whatever, but something happens in there. And the nerve as it is exiting the spinal column, the vertebrae, doesn't have enough room. And so it doesn't like that. And you'll get a radiating radicular pain, and then you'll sometimes get muscle spasm around it, which makes things even shorter. So then you get a pain cycle going. Spondylolisthesis is a movement of the vertebrae and translate one on top of the other. But what that is going to do is going to change the amount of room in the hole that those nerves have to exit out of, and it's going to result in some compression. You can also get viral infections. And then you've got your autoimmune conditions. Multiple sclerosis is one. Myasthenia gravis is where the transmission of the nerve signal is interfered with. Then we got neurotransmitter-based disorders. I talked to you a little bit about this. And then trauma in general. I mentioned that earlier in the discussion about the freeze response. Neuropathy is nerve pain in general. Headache caused by nerves. I mentioned the cervical plexus can be crowded in there, and it can be a cause for headache. So slow down, pay attention to this. Vertigo, which is part of the vestibular mechanism, makes you feel dizzy. And then this enteric-based pathology, remember I told you that the vagus nerve is part of this gut. And there's just starting to be more and more and more understanding about this. And then this breakdown of the autonomic or disrupted autonomic body process. A lot of times this is connected with the breathing, distorted breathing that I had talked about. This is difficult to diagnose. So just now realizing again how common this is. There were some conditions that they talked about with POTS syndrome or positional changes in position where all of a sudden you're dizzy or you faint or whatever. So this disrupted autonomic body process is an area where people can really not feel right. It's one of those, typically it's the wrong thing happening at the wrong time. So it's a normal process, but it's not happening in response to an appropriate signaling. Kind of takes on a life of its own. So just kind of be extra aware of this, that a lot of our clients are probably going to have some of this. You've got your summary, you've got your critical thinking, you have got your evolve site, and you've got these questions for review. And as always, you have your online course to accompany this chapter. So this is the one with the 25 questions, and here it is, module 5 to go with chapter 5. And then our last chapter in the textbook and in the online course that we'll talk about in the next video is the endocrine system. Lots of information to process here, lots of an understanding of how your own behavior, your own function, the way you have responded to different things, how that all is interfacing in the physiology, the physiological cascading interlaced chemical soup events that we have going on. And what's really cool with this, and you'll see this with the endocrine system as well, is the main methodology, the main treatment approach for dealing with these situations with a client or to support normal function with a client is the varied pressure, rhythmic, full body massage that lasts about 50 minutes and has some ambiance in the environment that helps the person settle and quiet. So practice, practice, practice that, because that will be what your main intervention is for any of these dysregulated aspects of the nervous system, as well as the endocrine system. Okay, there we go.